Welcome to the American Fertility Association's webcast, Dreams to Reality, the HIV and Parenthood Initiative. I'm Ken Mosesian, Executive Director of the American Fertility Association. I'd like to thank our sponsors, the Elton John AIDS Foundation for their generous educational grant, the HART program for their additional support, and Covenant of the Cross for hosting us today.
Good morning and welcome everyone. Very happy to be here in your beautiful city. As Ken mentioned, I practice reproductive endocrinology and infertility in Los Angeles, where I've been practicing for the last 24 years. And we have a very diverse practice. We see everything from basic infertility evaluation through to vitro fertilization, surrogacy, egg donation, very diverse practice. And in the last 5 or 10 years, we've been seeing several patients presenting to us who are infected with HIV, inquiring about different treatment options that are available. And today I'm going to talk about the progress that has been made in the treatment options that are available for individuals affected by HIV. And I'd like to start with a couple of thank yous. One to the Elton John AIDS Foundation for generously supporting this program. One of the primary missions of the Elton John AIDS Foundation is to help remove the stigma associated with HIV. And several years ago, when I was talking with Elton and his partner David about fertility work and presented the idea of talking about fertility options for individuals with HIV, we all thought it would be a wonderful way to enhance the work mission of the foundation to help remove the stigma. I can think of no better way to help remove that stigma than to talk about new life and babies. Also, the American Fertility Association, whose mission is to help educate all individuals on fertility treatment options, and the HART program, which is a newer semen wash sperm testing program for individuals with HIV. So the challenge here is really conception with minimal risk of transmission. We can't eliminate risk, but our goal is to minimize risk. And the goal is healthy baby, healthy mom, without acquisition of infection. Fortunately, the science provides background. It provides a foundation to achieve this goal. And the clinical studies over the last 10, 20 years have supported the safety of the treatment. And we're going to review those studies today. And lastly, I'm going to talk about the different treatment options available to help individuals conceive with minimal risk. Over the last 3 decades, the life expectancy for individuals infected with HIV has changed dramatically. In the late 1980s, when HIV was first discovered and being diagnosed, it led to a very short lifespan. Individuals would die 10 years after the diagnosis. With the introduction of AZT several years later, the life expectancy improved a little bit to about 20 months, but it was still, their lifespan was tragically short. In the mid-1990s, with the introduction of multiple regimen treatments, highly active antiretrovirals, the life expectancy increased dramatically. And today, individuals with HIV can expect to lead a long, normal life. HIV is now a manageable chronic disease. And with that long, normal life, individuals want to have options to have children of their own, to have families, and experience all the opportunities that people without the disease are presented. So what is HIV? Just for a brief review, HIV is a retrovirus that infects T lymphocytes, and it can lead to AIDS. The virus is found in blood, semen, and vaginal secretions. The predominant method of transmission is through heterosexual intercourse, with a rate of transmission somewhere between 1 in 500 to 1 in 1,000 acts of unprotected sex. the risk of transmission from mother to baby is greater than 20% in women who are not on antiretroviral treatment. And the serum viral load, the amount of virus present circulating in the blood, is one of the chief predictors of the rate of transmission of the virus. The risk factors for HIV transmission include the plasma or blood viral loads, any genital tract infection in the male, trauma with sex, lack of male circumcision, and any bacterial infection in the female, bacterial vaginosis, herpes infection, gonorrhea, chlamydia, syphilis, all can increase the risk of transmission. There is some correlation between the serum viral load and the amount of virus in the semen. It's not a direct one-to-one correlation, but in general, with a high viral load in the blood, there's high viral load in the semen. So this provides an opportunity for intervention, for treatment, to decrease the risk of transmission. And in this study, they presented a model that looked at the levels in the serum and the risk of infection. So individuals with high amounts of virus in the serum, 100,000 copies, for example, the probability of infection was 1 per 100 acts of intercourse. In individuals with lower copies, down to 1,000 copies, the risk of transmission was 3 out of 10,000 acts. So if we can lower the amount of virus in the serum, we should be lowering it in the semen and thereby lower the risk of transmission. And that's one of the impacts of antiretroviral agents. They significantly decrease the amount of virus in the serum, and that also result in a decrease in the seminal viral load that parallels a decrease in the serum viral load. In this study from Switzerland, they showed that in patients with treatment-induced suppression of serum viral load, the likelihood of finding HIV virus in the semen was less than 4%. So one of the goals of treatment here is to suppress the presence of virus in the blood, which leads to a decreased amount of virus in the semen, which should lower the risk of transmission. So what is in semen exactly? Let's get to the basic science. Semen is composed mostly of seminal fluid, 70% seminal fluid, 25% prostatic secretions, and only 5% sperm. And there's about 1% of some other secretions, and rare to few white blood cells. Well, where does the virus exist? Studies have shown that the HIV virus is not inside the sperm or even attached to the sperm, but it exists as a free-floating viral particle in the seminal fluid or inside a few white blood cells. So it makes sense that if there's some sort of infection, inflammation, you have increased number of white blood cells, that you're at increased risk of transmitting the virus. So this provides actually a basis for treatment for individuals interested in conception. So because the virus is in the white blood cells or in the seminal fluid, if you could remove the sperm from the white blood cells and seminal fluid, you should be able to separate it from the viral particles. And this is the basis for the early treatment of doing sperm washes to minimize the risk of transmission. And in this very early paper, 1992, by Dr. Semprini out of Milan, before anyone was doing this treatment, he began to treat individuals by doing sperm wash to help remove the virus from the sperm samples. And in 1992, he reported the first series of patients on 85 serodiscordant couples, 29 of whom underwent IUI, which means intrauterine insemination, with washed sperm samples. And after washing the sperm, he tested the sperm samples for the presence of HIV by doing some antibody testing. And he only did the insemination if those specimens were found to be free of virus. And he had 17 pregnancies in 15 women, And importantly, there were no seroconversions in the recipients or in the offspring. So this was the first report of IUI being used as a method to minimize the risk of transmission of the virus. Dr. Semprini reported a follow-up study in 1998, which he slightly modified the protocol in that after his sperm wash, he tested the wash sample with PCR, a more sensitive test to look for the presence of HIV virus rather than the antibody test. And in this report, he reported on 1,600 IUI cycles in 513 women. And there was just under 1% of those samples, post-wash samples, tested positive for HIV, 6 out of 623. There were 228 pregnancies, and again, no seroconversions in the mothers or the offspring. So supporting the earlier data showing minimal risk of transmission. So what is a sperm wash? And I'm going to walk you through the steps here, not because you're all future lab techs, but I just want you to have some understanding of it's a relatively simple procedure. So in the laboratory, we take a semen sample and we layer it onto a density gradient. So this is basically a test tube. We put the semen on top, and there's 2 different gradients, and then we're going to centrifuge it. We're going to spin it. And what happens in this process is the motile sperm, the good sperm, separate into a pellet in the bottom of the tube, the bottom of the density gradient, and white blood cells, the semen, and any viral particles are going to stay higher up in the tube. So after a half hour of spinning it, we're going to remove the upper layer, which contains potential virus and white blood cells, and the semen, and we're going to add some fresh culture media to our sperm pellet at the bottom, mix it up, centrifuge it again to mix it up, take our sperm pellet, and we're going to add culture media over it and put it in the incubator for an hour. And what will happen is the highly motile sperm, our best sperm in that pellet, are going to swim up into that culture media, and those are the sperm that we're going to use in our assisted reproductive procedures, because the sperm, if there were any contaminating viral particles, the theory is they're going to swim up away from it. And then that sample is tested for the presence of HIV, and then it can be frozen to be used in a reproductive procedure. And in the last couple of years, there have been a couple of review articles on the worldwide experience of doing sperm wash and in vitro fertilization using sperm wash techniques. And this paper from Savazzi et al., published in 2013, looked at 3,200 couples undergoing 6,200 IUI cycles and about 1,600 IVF cycles. There were 320 children born, and importantly, no seroconversions in the mothers or the babies. Again, supporting the safety of these techniques. It's important to point out that these are all retrospective studies. These aren't randomized studies. These are retrospective reviews of patients that have gone through this treatment. A more recent article is actually in Press in Fertility and Sterility as we speak on the efficacy and safety of intrauterine insemination and assisted reproductive technology in patients serodiscordant for HIV. They reviewed the world literature. They looked at over 200 studies. 24 clinical studies were selected for their meta-analysis, and these were seropositive males with procedures into seronegative females. They reviewed 8,200 IUI cycles, 1,254 IVF cycles, and there were no reports of transmission of HIV to mother or baby, again supporting the safety of these techniques. They then broke it down and looked at the pregnancy rates of women undergoing IUI, intrauterine insemination. The average age of these patients was about 35 years, and the pregnancy rate per cycle with this wash sperm that's gone through this special processing was about 17%, which is actually a normal pregnancy rate. In an infertility patient population, at age 35, the pregnancy rates would be significantly lower from an insemination of about 3%. So they're showing near normal pregnancy rates in these women undergoing insemination with this process. So what is the impact of HIV itself on male fertility? Well, we've seen in multiple studies a decrease in sperm parameters. There are reports of decrease in testosterone production, decrease in libido, increased incidence of impotence, and some ejaculatory dysfunction. So a generalized, what we refer to as hypogonadism in men with HIV. And specifically on sperm parameters, Dr. Nikopoulos has reported a decrease in semen volume, a decrease in sperm concentration, decrease in motility and morphology. And when we do a general semen analysis, the important parameters that we look at are concentration, motility, morphology, because they correlate with the ability of sperm to function. And the function of a sperm is to penetrate an egg. So men with HIV, we see a decreased functional capacity in many individuals. There's a positive correlation with CD4 counts. So if CD4 counts are normal, we see better sperm quality. Conversely, low CD4 counts, we see more of an impact on sperm. Of course, the core treatment for individuals with HIV is to be on highly active antiretroviral therapy, which has been shown to have a negative impact on sperm quality and quantity. And there's a negative correlation between duration of antiretrovirals and the sperm parameters. And in this study, they found that 9.7, just under 10% of men on antiretrovirals with undetectable viral load in their blood still had positive HIV in the semen. So again, there is a correlation between blood and semen, but just because we have it suppressed in the blood does not ensure the absence of virus in the semen. Because of the negative effect on sperm quality, after the sperm wash, we may end up with very low sperm numbers of marginal quality, which leads to the question, should we be doing insemination or do we need to go to IVF? IVF with ICSI, ICSI stands for intracytoplasmic sperm injection. It's one of the assisted reproductive techniques we use to facilitate fertilization. Low sperm numbers, fertilization rates may be 0 to 30%. With ICSI, fertilization rates 75 to 80%. So we can bypass any sperm functional deficit with ICSI. So we should consider going directly to IVF with ICSI in men with less than 2 million motile sperm after a wash. In any case where there's our female fertility factors involved, where you need IVF with ICSI to allow conception. Some individuals prefer to go to IVF with ICSI just to optimize the chance of pregnancy per cycle. A 35-year-old woman doing an IUI, she may have the 15% pregnancy rate per cycle. IVF with ICSI will provide her with a 60% pregnancy rate per cycle, so significantly higher. And you can make an argument that IVF with ICSI is an additional step to further minimize the risk of transmission, because rather than exposing the female recipient to millions of sperm in that sample, in IVF with ICSI, we take one sperm, inject it into each egg, so we're minimizing the risk of some viral contaminant around the sperm. And this diagram, just for those of you not familiar with IVFs, helps to illustrate the process. In an in vitro fertilization cycle, we give daily injections to the woman of follicle-stimulating hormone to stimulate her ovaries to make multiple eggs. Just prior to ovulation, under transvaginal ultrasound guidance, we'll insert a needle through the top of the vaginal wall directly into the ovaries to remove all of the eggs that have been developed in that cycle. And now, under the microscope in the laboratory, we can perform ICSI. And in the ICSI procedure, the human egg is held in place by the suction pipette, which you see on the left side of the slide, and the ICSI pipette on the right is like a really micro spear containing a sperm. We inject one sperm into the egg to facilitate fertilization. And this provides fertilization rates of about 75%, which is higher than one would expect in men with natural fertilization and low sperm numbers. The fertilized eggs are then kept in culture for 5 days to watch them develop and to determine which embryos have the highest chance of initiating the pregnancy. So that allows selection of the best embryos for transfer into the recipient. Dr. Mark Sauer at Columbia University in New York has been helping individuals with HIV have children for the past 10 or 15 years. And a couple of years ago, he published a 10-year retrospective review of his patients undergoing IVF with ICSI to have children. So he reported on 181 couples that had undergone 355 IVF ICSI cycles. There were 300 egg retrievals. The pregnancy rate per retrieval was 42%. And there were no seroconversions in the children or the mothers. So again, supporting the safety of the process, and he demonstrated pregnancy rates that were near normal. Now this is a mixed group of patients in terms of age, but relatively normal pregnancy rates in this group of patients. There's another approach to minimizing risk and to testing sperm, semen for the presence of HIV. Dr. Ann Kiesling of the Bedford Foundation and Harvard Medical School in Boston presented this prize-winning paper in October of 2007 at the annual meeting of the American Fertility Association. And her laboratory has developed an assay to check semen for the presence of HIV prior to the sperm wash. So in the Bedford protocol, they combine PCR HIV testing on semen, and they proceed with sperm washing only on those samples that have tested negative for the virus. So you test the semen for the virus. If it's virus-free, then do a sperm wash to minimize the risk and separate the sperm. And those samples are then used in IUI cycles or IVF treatment cycles. And this is a brief review of their data. From 2000 to 2006, they tested specimens from 262 men with HIV. And about 19% of those specimens tested positive for the virus and were discarded. 151 couples proceeded to assisted reproductive techniques, and they had 69 pregnancies, 62 babies, and 10 sets of twins. Between 2007 and 2011, they tested 826 specimens from 368 men. And again, about 18% of specimens tested positive and were discarded. And 172 couples proceeded to assisted reproductive procedures with 87 pregnancies and 96 babies born. And as of May of this year, through 68 collaborating fertility clinics, there have been 193 babies born, and all moms and babies have tested negative for HIV. And their goal is to have 400 babies born for their study to show a significant power to confirm the safety of the process. In women with HIV, the risk of viral transmission to the baby is greater than 20% in women who are not undergoing treatment with antiretroviral medication. The introduction of a single antiretroviral agent can decrease the transmission risk to about 5 to 8%, and with combination antiretrovirals, we can further lower that risk to less than 2%. And there have been studies recommending the use of C-section to perhaps lower the risk further, and women with HIV are advised not to breastfeed to avoid transmission of virus to the baby. The impact of HIV on a woman's fertility, we see oftentimes irregular menstrual cycles. Women may not ovulate. They may have prolonged periods of amenorrhea, which is lack of menstrual periods. And we're not sure the cause of this. There have been some studies suggesting that perhaps their ovaries are showing signs of decreased ovarian reserve and premature aging. Other studies haven't confirmed that. In women with HIV, there's multiple studies showing increased risk of tubal occlusion. And this may be a direct effect of HIV on the fallopian tubes, or maybe indirect. In general, we know that women with HIV are less likely to conceive than uninfected women, and women with advanced disease and lower CD4 counts generally have lower pregnancy rates and live birth rates. Studies from the United Kingdom have shown increased incidence of pregnancy terminations in women diagnosed with HIV. And there's a few studies looking at IVF pregnancy rates in women with HIV, some suggesting lower pregnancy rates. There's really not enough data to make a conclusion with that. Women on antiretroviral agents, these agents are known as mitochondrial toxins, which may have a direct impact on egg and embryo competency to initiate a pregnancy. So the lower pregnancy rates may be related more to the medication, not necessarily the HIV virus itself. The antiretrovirals are critical to reducing the viral load to undetectables during pregnancy. It's very important that women are followed closely during their pregnancy, not only by their high-risk obstetrician, but by their HIV specialist with serial viral load counts. And importantly, studies have not shown any increased incidence of birth defects in women on their antiretroviral agents during pregnancy. Pre-fertility treatment evaluation for women should include a viral load and CD4 levels, preconception counseling about the risks and the importance of staying on the antiretroviral agents during pregnancy to minimize the risk of transmission to the baby. I think it's very important to have a fertility evaluation before attempting conception, because if there are any infertility factors, you want to diagnose them and treat them, bypass them quickly. And to consult with a high-risk obstetrician who can follow you during your pregnancy. The pre-treatment infertility evaluation should include an assessment of ovarian reserve. So ovarian reserve refers to testing of the ovaries to get an idea of where they're at in the reproductive lifespan. Two simple ways include a blood test for AMH, which stands for anti-Mullerian hormone. And as a woman ages, the total number of follicles remaining in the ovaries diminishes, and we'll see a decrease in AMH levels. FSH and estradiol are hormone levels checked on the third day of the menstrual cycle that also give us an idea of ovarian reserve and help predict how well the ovaries will respond to fertility treatments. It's important to confirm ovulation due to the reported increased incidence of anovulatory cycles in women with HIV, and a pelvic ultrasound to rule out any gross pathology, tumors of the uterus, ovaries, endometriosis. A hysterosalpingogram is a basic test of pelvic anatomy that tests for tubal patency and normalcy of the uterine cavity. All women should have infectious disease screens, and their partner should have a semen analysis so we know whether or not their partners may need some treatment themselves. Treatment options for serodiscordant couples fall in two general categories. We've talked about in vitro fertilization with ICSI, and these procedures can be carried out with semen that's been tested for HIV, for example, through the Bedford program, and then washed to minimize risk. Or other protocols involve washing the sperm and testing that washed specimen for the presence of HIV, and then proceeding to IVF with ICSI. IVF pregnancy rates in general for a woman in her mid-40s is going to be approximately, in her mid-30s should be approximately 60%. Second category of treatments would involve doing an intrauterine insemination, or IUI. And we can proceed with an IUI with semen that's been tested for HIV through the Bedford protocol and then washed, or we can do an IUI with washed sperm that's subsequently been tested for HIV, or some programs may feel comfortable doing an IUI with washed sperm without PCR of the washed specimen due to the low risk of there being virus present in a male partner who's on highly active antiretroviral treatment with negative serum viral loads. And I think which treatment option is best for a given patient will rely on that discussion between the patient and their physicians and assessing all of their risk factors and a clear discussion about which steps they're comfortable with, which risk options they're comfortable proceeding with. Pre-exposure prophylaxis, or PrEP, refers to antiretroviral agents that are used either continuously or before and after sperm exposure. And they can be given as a vaginal gel, and there's mixed results in studies with vaginal preparations for HIV prevention, or as an oral tablet daily, either tenofovir or tenofovir emtricitabine, tongue twisters, these drugs, or Truvada. And studies have shown that they can decrease the risk of HIV transmission by 65 and 75%. So this opens up the possibility of an additional treatment for serodiscordant couples, namely using PrEP with ovulation-timed intrauterine insemination and washed sperm, or PrEP with ovulation-timed unprotected intercourse, or ovulation kit timed unprotected intercourse without PrEP. And there's not a lot of data on PrEP for safer conception, but there are a couple of studies in the European literature. In this study out of Switzerland, Dr. Vernazza followed 37 serodiscordant couples. These were HIV-positive males on antiretrovirals for at least 6 months. And there were 170 intercourse time cycles with an ovulation kit. And the uninfected female partner took tenofovir or Truvada, 1 tablet on the morning of the ovulation kit change, and 1 tablet 24 hours later with intercourse. He reported a 75% pregnancy rate, and importantly, there were no seroconversions in mothers or babies. A second study out of the United Kingdom published this year, utilizing PrEP for safer conception. Dr. Taylor reported on 32 serodiscordant couples. The males had undetectable plasma and seminal HIV viral loads. The female recipients underwent full fertility screens. Both were screened for STDs, and they had timed ovulatory intercourse, and they used Truvada, which is tenofovir and emtricitabine, before and after timed intercourse. There were 11 pregnancies in 10 couples, 7 live births and 1 ongoing pregnancy, 4 miscarriages, and no seroconversions in mothers or babies. In May of this year, the CDC published clinical guidelines for the use of PrEP for the prevention of HIV in the United States. And their guidelines call for daily oral PrEP, tenofovir and emtricitabine or Truvada. They state that it's been shown to be effective in reducing the risk of HIV acquisition, and they recommend daily PrEP as one prevention option for men who have sex with men who are at substantial risk, for adult heterosexual men who are deemed to be at substantial risk, and for adult IV drug users at substantial risk. And the guidelines state that PrEP should be discussed with serodiscordant couples as one of several options to protect the uninfected partner during conception and pregnancy. The prescription of oral PrEP for quarterly timed or continuous or non-continuous daily use is not recommended according to the current guidelines, and these recommendations are really based upon the low number of clinical studies yet for PrEP around the time of coitus for safer conceptions. So in summary, on periconception PrEP for safer conception, there's really little data yet. Studies are underway. The few studies are small retrospective series of patients, but they seem to be supportive. The infected male partner should be on antiretroviral therapy with fully suppressed HIV viral load for this to be an option to consider. Only combination Truvada is currently being studied in heterosexual PrEP trials, and couples should be counseled to use condoms at all other times except during periovulatory intercourse in these protocols. And importantly, there's no reported increase in congenital anomalies for children whose mothers were exposed to tenofovir or emtricitabine during pregnancy. Potential limitations to PrEP for safer conception, that as we've talked about earlier, men, women on antiretrovirals with undetectable viral loads may still have virus in the genital tract, so it's not risk-free, and there's still some concern about potential teratogenic effects of the antiretrovirals in the babies. And viral load suppression in the HIV-positive male and female are both highly dependent on adherence to the protocol. So it's important to continue to take the medication and to not go off them for periods of time, or you're at risk of the viral load increasing again. So what are the fertility options for HIV-positive gay men? Well, for the past 20 years in our practice, we've been helping gay men have biological children through the combination of egg donation and surrogacy. Our individuals who are HIV positive, we do semen testing for the presence of HIV. In our practice, we've been working with the Bedford Protocol, and we proceed once we have 2 semen samples that are found to be virus-free through the Bedford testing protocol. We then do the swim-up sperm prep protocol to further minimize risk. And then in the IVF cycle, we will do ICSI as a third step to minimize the risk of transmission. And in our experience over the last several years, we've done 56 treatment cycles. There have been 44 pregnancies, either ongoing or delivered. Pregnancy rates are high because we're using young donor eggs of high quality with embryo transfer into gestational carriers who are women with proven fertility and completely normal fertility evaluations. So the pregnancy rates have been about 79% for transfer. And importantly, all surrogates, all babies have shown to be HIV negative, and we've resulted in 100% very happy dads through this process, as you can imagine. Individuals always ask, is it difficult to find surrogate mothers who are willing to work with HIV-positive dads? And it provides an additional challenge, but it's not as difficult as you might think. And we've worked with some wonderful surrogacy agencies, and I've listed the ones here that we've worked with for HIV-positive patients: the Center for Surrogate Parenting in Los Angeles, Circle Surrogacy out of Boston, Growing Generations Los Angeles, West Coast Surrogacy, Surrogate Alternatives, British Surrogacy Center of America. You know, we're fortunate to have in California some wonderful surrogacy agencies who help all individuals who want to have children. And surrogate mothers are these amazing women who are committed to the process. They're proud to be surrogates, and their reward is to be able to hand over this baby to the intended parent. And that's a driving force for them. And they're quite amazing, I have to say. So how do you get started if you're HIV positive and you want to explore having children, building a family? It's important to consult with fertility specialists to discuss what options are best for you, depending on your clinical situation. Critical that you follow up with your HIV physician and to check your viral load, CD4 levels, and to review your antiretroviral medications during the process. And that's what I have. Thank you for being such a great audience.
Thank you, Dr. Ringler.